pneumothorax is a condition in which air has accumulated inside that pleural cavity but outside the lung. So what this does is it kind of takes the lung off of the wall there, and it creates this space, and it won't let that lung expand fully during inspiration. So what you'll hear this often referred to is a collapsed lung. And the degree, how bad the ventilation is impaired, it depends on how much air is in that space, because the more air that accumulates in that space, the less the lung can expand. Now, usually, a lot of times the pneumothorax is a result of trauma, but you can have medical patients who have a spontaneous pneumothorax as well without any kind of trauma. And so when it occurs without trauma, it's called a spontaneous pneumo. Now, a lot of lung diseases, lung cancer, COPD, these result in these little weakened areas of the lung tissue called blebs. And what those do are they can just rupture, coughing, or sometimes just spontaneously, hence the name, because whatever. You may also have some individuals who are otherwise healthy but are at higher risk to a spontaneous pneumo. They think it could have something to do with a kind of weakness in some of the connective tissues of the lung, but typically those patients are going to be your young, tall, thin male patients. As well as coughing, you also have activities that can lead to increase in intrapulmonary pressures, such as exhaling when lifting something heavy against a closed glottis, like you're bearing down. Something like that can also potentially cause a pneumothorax in those patients. So a simple pneumo is when you have that area of the lung ruptured, air leaks out, and it's going to accumulate in that pleural space. Most of the time, the effect in the lung is very small and is self-sealing, so it's going to limit how much air can actually escape from the lung. So this is called a simple pneumothorax. It can be kind of deceiving, though, because it may not be simple at all. If a lot of air leaks into that pleural space, then that could be a substantial problem, leading to respiratory distress and hypoxia. Now, your spontaneous pneumo patients may present with pain. They may have a sudden onset of dyspnea, and they may or may not have had a coughing fit or some kind of activity that would increase that intrapulmonary pressure prior to the onset of dyspnea. As far as our lung sounds go, lung sounds are often going to be absent in the affected area, but it can be difficult to detect unless it's a very large pneumothorax, because if it's just a very small area, you may not notice it. Breath sounds can also be, transmitted across the chest wall from a functioning area of the lung to a non-functioning, so it can be very difficult to interpret this. And so what you may hear is that it sounds diminished as opposed to just absent, so it's just not going to sound as loud. And then on top of it, complicating even further the assessment of your breath sounds, the air of the pleural space sometimes can collect at the top of the pleural cavity. So at top depends on where that patient's positioning is. If they're laying down, top's going to be on the anterior. If they're prone, it might be on the posterior. If they're sitting up, it may be towards the clavicles. So it really just depends on their positioning as well. Your other indications that you may get of a simple spontaneous pneumo depend on the severity of that pneumo, how big that pneumothorax is. They could have tachypnea, they could have tachycardia, they could have a decreased SpO2. It just depends on how severe it is. So your suspicion should go up with patients who have a history that have the risk factors for spontaneous pneumo. And as far as management goes, their level of distress and SpO2 values are going to guide how much oxygen and how we give supplemental oxygen to this patient. Let the patient have a position of comfort when we're transporting, which should usually be sitting up. Provide some reassurance. Okay, if their ventilations are inadequate, then assist using a BVM type device. But we know positive pressure is going to increase your intrapulmonary pressures, but it's also going to increase the leakage of air from that affected lung. So we want to use the minimum amount of force necessary to achieve this adequate ventilation. So you really want to be careful with your ventilations and your bag squeezes here. Okay? If resistance starts going up when you are bagging them, suspect that it has developed or is developing into a tension pneumothorax, which we'll talk about in just a minute. We are never, ever, ever going to use a CPAP or administer nitrous oxide to a patient with a suspected pneumothorax. All right, as far as IV goes, mild distress, condition is stable, may or may not require an IV in the pre-hospital setting. Moderate to severe distress needs to have an IV access. And make sure that you're reassessing frequently. Make sure you're monitoring the mental status, because direct correlation to respiratory status, breathing, lung sounds, oxygenation, and vital signs. Now, the tension pneumothorax. In some cases, the defect is too big and it cannot reseal itself. So this happens when, say, the rupture of the lung includes a larger bronchi or bronchus, and the air is going to continue to accumulate and can't get out. So the pressure is going to increase in the thorax, and it's going to affect the lung on the affected side. It's going to compress it, and then it's going to start pushing the structures in the mediastinum towards the other lung, and it could finally collapse the other lung as well. And this is called a tension pneumothorax, and it is critical. It is a life threat. Okay, so in addition to all the signs and symptoms of your simple pneumo, you also will have severe dyspnea. It'll progress to severe dyspnea, respiratory failure, cyanosis, often profound cyanosis, distended neck veins, or JVD, you may hear it called, for jugular venous distension, and hypotension. Okay, and a very, very, very late sign of this condition is tracheal deviation, so it will deviate away from the affected side. If you see that, either you just got to them and it's really bad, or you've missed some other warning signs along the way. Okay, you know, as far as the mortality and morbidity associated with this, with the tension pneumo, it's because it creates a form of obstructive shock. It's going to affect the oxygenation of the body. Okay, that high intrathoracic pressure is going to impede your blood return back to the heart, like a massive positive pressure ventilations, and it's going to reduce your cardiac output, which is shock. All right. Now, at the paramedic level, you can perform a procedure called a needle thoracostomy or needle chest decompression. And so what this does is it actually gives a relief valve to that air. So it is a life-saving intervention. So you may have to decide to make that transport decision that's going to get your patient the intervention the most quickly. So depending on where you are and what type of response you run, it may be getting a paramedic response. It may be transporting as quickly as possible. It may be meeting them on the way. Okay, ventilation in this case can increase the amount of air escaping from that damaged lung. So once again, use the least amount of pressure that you need to ventilate that patient. Start your IV, infuse the fluids for your hypotension, and notify the receiving facility of your suspicions as soon as you possibly can so they can be ready. So to compare with our dyspnea, all right, in a simple pneumo will be mild to severe, and a tension will be increasingly severe, progressing to failure. Our hypoxia in a simple will be mild to severe, and usually on the milder side, and our tension will be increasingly severe, so it's going to get worse and worse and worse and worse. Our lung sounds, okay, on a simple are going to be decreased on that affected side, and on a tension are going to be decreased at first, but then it will be decreased on both sides and eventually can be absent. All right, your chest pain, simple, may or may not be present. In tension, they say it's present in about 90% of the cases, so more than likely you'll have chest pain for that patient. In circulation, simple, may have tachycardia, but it's usually more related to anxiety and dyspnea. In tension, you will have hypotension and tachycardia related to the shock, the poor perfusion. It's going to have impaired blood return, decreased preload to the heart, so we're going to call some JVD. Okay, and eventually can progress to cardiac arrest. And then some other things that you may see, okay, simple pneumo, usually none, but tension, you may see pulsus paradoxus, which is where that pulse at the radial pulse actually kind of decreases with inspiration. That's because those increased pulmonary pressures. You may see tracheal deviation away from the affected side. You may see hyperexpansion of the chest, and you may have hyperresonance to the chest to percussion. All right, so you don't usually see these though, so just because they're not there doesn't mean that it's not a pneumothorax. You may have a tension pneumothorax without those signs, so don't rely on just those to diagnose.